Good evening, I'm Dr. Himanshu, consultant cardiology at Max Specialty. Today I'm going to present this is a simple case, simple as a routine day-to-day presentation. ये work नहीं कर रहा है. Good evening. This is a routine case which we see in our daily ICUs or wards. This is a 60-year-old male who has a multiple comorbidity. He is a chronic smoker, COPD, hypertensive, diabetic, peripheral occlusive disease, and chronic kidney disease. He presented in Pushpanjali Medical Center with complaint of shortness of breath since last 1 day. On presentation, he was BP was 90/60 triple inotropes, pulse was 120, saturation 80% room air, and in chest bilateral cracks were present. Initial ECG showed, this is a routine ECG which shows enormous sinus rhythm, LVH with strain pattern. We can see there is some STT changes, but on background of hypertension, we suspect that this is due to the hypertension. X-ray shows bilateral OPCDs, most likely of pulmonary edema. Blood investigation shows CBC was raised TLC, KFT drainage, and ABG show type 2 respiratory failure. So initially, for the first 12 hour, patient was managed as COPD with type 2 respiratory failure. He was intubated and put on mechanical ventilator. Then cardiology review was taken. His cardiac enzyme were pending at that time. Then 2D echo was done, we showed LVF is 25% and hereditary hypokinesia. Blood investigation come, his TROPI was positive, anti-proBNP was raised. Then what are the issues in this case? First, patient was on mechanical ventilator. He was in cardiogenic shock, low ejection fraction, multiple comorbidity. So there is some things that should we transfer the patient to higher center or manage here? Because of multiple comorbidity, patient were explained, attendant were explained that prognosis was not good. So loading dose was given, injection heparin given, put on inotropes, Lasix infusion was given, and advised to shift to higher center. So there were issues. So there's some issue that should we go in early invasive strategy or stabilize the patient, then do some investigation angiography. If angiography was planned, then should we go for radial approach or femoral approach? Then because he was in cardiogenic shock, so we have to take some IVP support, left ventricular support system or Impella. His angio was done, which shows left main was normal, LED 99%. LCX normal and RC was 100%, which was filling from the left side. This was his angiography. LED was 99%. And we can see that RC was also filling from this side, right coronary artery. Then we put a wire in this, dilated with balloon. And Timothy was achieved. So he was managed with the radial approach only. There is no IVP support was taken because patient was peripheral occlusive disease, bilateral femoral artery. There is some stenosis was there. What was the good outcome is patient was shifted to CCU, extubated next day, inotrope tapered off, and multiple opinions from the pulmonary team, nephrology team was taken. His echo showed, initial echo showed there is a LED hypokinesia, decreased EF. Post PCI after 2 days, we can see that his heart has improved to normal. Discharge on day 4. So what are the learning lesson in this case? This is a simple case, routine case, which we see in normal life. We see that patient has multiple comorbidity, he is sick, so we can leave it. But in this we took multidisciplinary approach, medicine review, nephrology review, and pulmonary. We manage patient together. Early and timely interventions. Patient was shifted timely to the higher center, and then radial approach was taken in the critically ill patient. So this is okay. Next, just I want to see that yesterday we done a tower, wall-in-wall tower at Max Vaishali. This was a 70-year-old male. His CAD post CABG post AVR. So in this wall was already there because he was post CABG post AVR. So through the femoral approach we implanted another valve. And patient yesterday valve was implanted. We will discharge the patient tomorrow. Thank you.
Thank you, sir. Any questions? Yeah.
Yes, sir.
Excuse me, what if we see ST elevation in anterior atrial veins?
Yes, sir.
That is a global event inversion.
Yes, sir.
The physician is almost working remotely from that place where the facility for reperfusion or PCI is almost 6 hours away from there.
Okay, sir.
How should he proceed?
Sir, if patient was in the patient is vitals are stable or unstable. If vitals are stable, then we can transfer the patient to the higher center on the heparin infusion. If vitals are not stable, then we should manage the patient there with the anticoagulant only. Because we are lucky that he transfer time only half an hour from here to Max Vaishali, so that we can manage the patient. There was his ventilation was okay and perfusion was maintained through the inotropes. But if he is 6 hours from this place, so we should maintain stabilize the patient there only. But if we can transfer to patient at 2 hours or 1.5 hours, then we should shift the patient.
Sir, one more question. Like in many cases, like where we see ECG changes, they mimic or they simulate like ST elevation, and it's not involving any coronary pressure.
Okay.
Right? So in non-coronary condition, like so in case then it's I think mandatory for biomarkers to be.
Yes, sir. Cardiac marker should be done because there are many other causes for the ST elevation, if pericarditis, pancreatitis, sepsis, and we can see if there is some due to the LVH, we also say there is the STT changes also. So we should go for the echo and the cardiac marker. If cardiac marker are raised, then we should suspect towards the myocardial infarction. Because this patient was initially suspected because known case of COPD, present with shortness of breath, ABG show type 2 respiratory failure, managed as COPD with CO2 narcosis. But after coming the reports, then we can manage and salvage the patient. Thank you, sir. Thank you, sir.